start the first session by دكتورة أدينا مباشر about مينوكا. مش سامعين الناس، مش سامعين صوت الناس اللي معانا.
I can't hear you. هم عاملينك ميوت.
هم تقريبا
بس هو لازم
دكتور صبحي معانا، الصوت واضح؟
ما اعرفش هم فين.
دكتور صبحي؟
هم عاملينه هاي.
دكتور صبحي؟ الو؟
محمد طارق معانا.
ايوه معاك. ابتدي ولا لا؟
Yes, we first we welcome all the chairpersons and we will start the session by Dr. Adina Mubashir. Dr. Adina.
اوكي.
Can we share the presentation?
Bismillah ar-Rahman ar-Rahim. Good morning. We are going to present the case of a male patient, 27 years old, not known to be diabetic nor hypertensive. He's a smoker.
Sorry, we cannot see the slides. You share the screen, please.
How?
Share the screen.
Yes, okay.
Okay.
Full screen now, full screen. Make it full screen.
Okay.
Yes, okay.
He's a male patient, 27 years old, not known to be diabetic nor hypertensive. He's a smoker. Presented with acute return chest pain of 10 hours duration and upper respiratory tract symptoms for a few days. ECG was done for the patient, showing ST elevation in inferior leads and reciprocal depression in lateral leads as shown in the picture. Rapid echo assessment showed no segmental wall motion abnormalities and normal LV ejection fraction. Cardiac enzymes are positive. What would you do next? Is it to start thrombolytic therapy or transfer to cath lab for primary PCI? Since we are a primary PCI capable center, so the decision was to transfer to primary PCI. Here is the coronary angiography. This is the REO caudal view, showing the left anterior descending artery normal and left circumflex artery also normal. Here is the REO cranial view, showing the left anterior descending artery, no significant lesions. Here is the LAO cranial view. Spider view. Right coronary artery, dominant, normal. And the cranial view for the right coronary artery. So now we are dealing with a Minoka case. Minoka is myocardial infarction with non-obstructive coronary artery. So what's next? How to proceed with the case? This will be discussed in the upcoming lecture. Thank you.
Thank you, Dina. Now, in the context of this case, we are supposed to tackle some lectures that will also approach Minoka and how to manage and diagnose it. So, Dr. Nabil Farag, is he online with us? Okay, so we will start with the first lecture, Minoka, Novel Insights of an Uprising Enigma. It will be presented by Professor Nabil Farag, Professor of Cardiology, Ain Shams University.
Good morning, everybody. I would like to thank Dr. Hussam Hassan for inviting me to give this presentation, and I would like to thank Dr. Ashraf Badawi, the IELTS company, and his group for this very good
ممكن
organization.
نغير الشاشة؟
And this is my presentation today. It's about infarction with non-obstructive coronary artery disease. This is the title of my presentation. It is Novel Science of Uprising. Actually, this title is difficult, and I would like to explain the title first before explaining my presentation. Noble Insights is to have a clear understanding of a very difficult problem, which is difficult to understand, which is a MINOCA or myocardial infarction with non-obstructive coronary artery disease. I will start with an actual case. I faced this case in the hospital. This is a lady, is a 45-year-old lady. She's hypertensive on metoprolol with a past medical history of hysterectomy. She presented with a persistent chest pain associated with profuse sweating, and her blood pressure was 110/70 and heart rate was 66 beats per minute because she was taking this beta blocker, metoprolol. Her ECG showed an anterior ST elevation MI. She received ticagrelor loading dose of 180 milligram and chopped aspirin 150 in the ER. And because of this acute presentation in a primary PCI capable hospital, she was transferred immediately to the cath lab where coronary angiography was performed. His ECG showing an ST elevation V1, V2, V3, V4, mild elevation in V5, denoting an anterior with stagnation of the contrast material in this LED, denoting a slow flow, and this slow flow can be explained by microvascular disease. There is some tortuosity over LED, and this is the right coronary artery or the dominant artery. Again, it was normal artery. So she's having a normal coronary arteries, but presenting one with an ST elevation, MI, some slow flow, some stagnation of the blood in the LED, and this could be explained by microvascular dysfunction. Actually, this is our case, which is a lady presenting with typical chest pain and with rising troponin, ECG showing an ST elevation in the anterior chest lead, denoting an anterior infarction. We did a coronary angiography. There was no significant coronary artery stenosis, and her LV function was normal and no apparent cause for other presentations. This is a classic definition of myocardial infarction with non-obstructive coronary artery disease. Let's go to the epidemiology of this disease. Actually, the prevalence rate of this disease, if we consider a patient with totally normal coronary artery, so the prevalence rate will be 1 to 4%. But if we take other patients who have obstruction of less than 50%, the prevalence rate will be between 10 and 14% of all ST elevation myocardial infarction presentation. And about 1/3 of these patients will be presented with ST elevation MI, and 2/3 will be presented with non-ST elevation MI. Usually, this myocardial infarction with non-obstructive coronary artery disease occurs in female at younger age. This is very characteristics, like the patient presented, and 25% will have recurrence of their anginal chest pain within 12 months. Despite the fact that this syndrome, it is not a disease, it is a syndrome, and we'll explain this later, has been examined in greater depth over the past few years, many uncertainties remain as regard the pathophysiology of myocardial damage, the clinical features, the management, and the prognosis of these patients. Still, we don't have a randomized clinical trials addressing all of these issues as regard MINOCA. As a result, the patients may be treated inappropriately or not treated at all. We have different terms as regard this. One of them is a MINOCA, which is a myocardial myocardial infarction with non-obstructive coronary artery disease. The other term is MENCA, which is a myocardial infarction with normal coronary arteries. And the third term is INOCA, is ischemic obstructive coronary artery disease. All of these terms, this syndrome. The term MINOCA is incorporated into the recently published universal definition of acute myocardial infarction. So this is the commonly used term, the MINOCA. The potential mechanisms behind this complex disease and behind this syndrome, number one is plaque disruption. And plaque disruption, we can diagnose this plaque disruption by imaging technique like OCT and IVUS. Second proposed mechanism is a vasospastic angina and vasospastic disease. And this again can be diagnosed by provocative tests like injection of intracoronary acetylcholine. Third is spontaneous coronary dissection. Spontaneous coronary dissection, we saw this dissection especially in females and common during pregnancy. And again, this can be diagnosed by imaging technique, but take care that advanced the wire in this condition will be dangerous. Fourth mechanism of this plaque disruption, thromboembolism, and this thromboembolism could be due to atrial fibrillation or left ventricular thrombus that embolize in the coronary arteries. A fifth mechanism, like the case I presented, is a microvascular dysfunction, and lastly, supply-demand mismatch, for example, in patients with severe left ventricular hypertrophy due to any cause. That's why diagnosis. But MINOCA is a clinical syndrome, including all of this: rupture, vasospasm, spontaneous coronary dissection, thromboembolism, microvascular dysfunction, supply-demand mismatch. What are the challenges we face in identifying MINOCA? Number one, MINOCA is a specific term. It's a myocardial infarction. This means that ischemia necrosis as per fourth universal definition of acute myocardial infarction. Or we can consider MINOCA as a generic term, myocardial injury. Myocardial injury due to any cause. It shouldn't be a myocardial infarction. It shouldn't have ST elevation. And the alternative to this MINOCA, we can use what we call troponin positive with non-obstructive coronary arteries. And this is the troponin positive with non-obstructive coronary arteries could be due to many causes. Causes due to coronary disorders, and this is referred to MINOCA, plaque disruption, coronary spasm, microvascular dysfunction, and coronary thrombosis. Second, due to myocardial disorders, and these myocardial disorders are not considered MINOCA, like myocarditis, Takotsubo cardiomyopathy, or other cardiomyopathies like hypertrophic cardiomyopathies, and non-cardiac disorders like pulmonary embolism, renal impairments. Myocardial disorders and non-cardiac disorders are not considered MINOCA. MINOCA are due to mainly coronary disorders that I mentioned before. And this, how can we diagnose this syndrome? We have to diagnose the etiology or the causes of this syndrome from the clinical history, from ECG, from the echocardiography and cardiac biomarkers. So in a patient presenting with chest pain, ECG changes, suspecting a myocardial infarction with elevated troponin, we have to go for a coronary angiography, and we have to perform left ventriculography, because the Takotsubo cardiomyopathy have a very characteristic form of left ventriculography. I will explain this later. So by left ventricular angiogram, we can diagnose Takotsubo and excluding this from MINOCA. Other forms, if we have suspected unstable plaque, we can go for IVUS or OCT, as I mentioned before. If we suspect functional coronary alteration, vasospastic disease, we can go for a provocative test like intracoronary injection of acetylcholine, which is actually not considered a MINOCA, we can send this patient for cardiac MRI, or we can take an endomyocardial biopsy. If we suspect microembolism, we can do transesophageal echo, especially in a patient with atrial fibrillation or left ventricular thrombus, or we can do an contrast-enhanced echocardiography, and all of these tools can be used for the diagnosis of the causes of this important syndrome and not a single entity or a single title. And this is how can we diagnose Takotsubo cardiomyopathy from left ventricular angiogram. This is the shape of the left ventricle in Takotsubo disease. It became similar to octopus trap. Octopus trap, like this exactly. This is a Japanese octopus trap. It's called the Takotsubo. So the term Takotsubo came from the Japanese octopus trap because of the shape of the left ventricle during left ventriculography or during left ventricular angiogram. One of the most important imaging technique we can use to differentiate different causes of MINOCA is a cardiac MRI. It's published in the Journal of American College of Cardiology in January 2017 that cardiac MRI imaging is a key investigation in identifying the underlying cause. Recent reports claim that cardiac MRI identifies the underlying cause in as many as 87% of patients with MINOCA. And this is the different cause of MINOCA as diagnosed by cardiac MRI. It was found that acute myocardial infarction representing 24% of the cases of MINOCA, myocarditis 33%, the Takotsubo cardiomyopathy 18%, direct cardiomyopathy 10%, and hypertrophic cardiomyopathy 3%, others 7%, and in 20 was not known. What about the prognosis of patients presenting with a myocardial infarction with non-coronary artery disease as compared to those with obstructive coronary artery disease? Actually, the prognosis is much better than those with obstructive coronary artery disease, and in long-term follow-up over 12 months. The prognosis, as we see here, is much better than those with a myocardial infarction with obstructive coronary artery disease. If we go to the management of this important syndrome, actually the fundamental consideration is identifying the underlying cause of this heterogeneous. As we saw before, we have many reasons for this syndrome because this will determine the appropriate therapy. And this, to summarize, how can we treat and diagnose this? We have to go definitely for coronary angiography if we have an obstructive coronary artery disease. Obstructive coronary disease means that a coronary stenosis of more than 50%, and this treated in the usual manner of an MI with dual antiplatelet therapy, statin, ACE inhibitors, ARBs, and beta blockers. But if we have a non-obstructive coronary artery disease, we can go for, based on what we suspecting, IVUS, OCT, we can do some provocative tests if we're suspecting vasospasm. We can use a coronary flow reserve testing if dysfunction. So if we have a plaque disruption, this plaque can be treated exactly like those with obstructive coronary artery disease. If we have a coronary artery spasm, as diagnosed by provocative, can treat this condition by calcium channel blockers, nitrates, if we have a microvascular dysfunction, we can use anti-anginal therapy, specifically calcium channel blockers, beta blockers, ACE inhibitors, and statins. If we have a coronary embolus from atrial fibrillation, for example, we have to use anticoagulants, or we can add to these anticoagulants antiplatelets. And we have to treat hypercoagulable states if we have some form of hypercoagulability as a cause of this coronary embolus or coronary thrombosis. Spontaneous coronary dissection, we have to be very cautious in this, especially they are females, and usually they are pregnant females. And conservative treatment is a treatment of choice in this spontaneous dissection. And this can be treated by aspirin, beta blocker, and we may consider clopidogrel, ACE inhibitors, and statins as well. In unstable patients, we can go for hypertension, but this is only restricted for a patient with severe instability. Otherwise, conservative treatment or spontaneous coronary dissection is the preferred treatment. In case of supply-demand mismatch, we have to treat the underlying etiology. If we have due to aortic stenosis, severe aortic stenosis, we can treat aortic stenosis. If we have hypertension due to hypertension, we have to treat hypertension. So we have to treat the underlying cause in case of supply-demand mismatch. So my conclusion is that myocardial infarction should not be considered as a final diagnosis, but should be considered as a syndrome requiring a working process to reach to the etiology and the diagnosis. It requires routine evaluation for treatable underlying causes. And as we mentioned before, based on many studies, that cardiac MRI imaging is a key investigation in identifying the underlying etiology of this important syndrome. Thank you for attention.
Thank you very much, Professor Nabil, for this elegant and conclusive lecture, which you didn't miss any point. We are very happy to have you with us. And then for the sake of the time, we will go to the second speaker, Professor Chiara Baxideli from United Kingdom. She is Associate Professor in Non-Invasive Imaging of Bristol since 2010, co-director of Clinical Research Imaging Center in Bristol also, past EACVI Vice President, and the chairperson of the cardiac MRI since 2016 to 2018, editorial consultant of JACC Imaging since 2017, editorial board of the European Heart Journal Cardiovascular Imaging since 2012. And she will give us, I have the honor and the pleasure to invite her, and she will speak on the MINOCA, role of imaging in MINOCA.
Good morning, and thank you so much for this invitation. It's really a pleasure and an honor to be with you. So, as you said, my talk is about multimodality imaging in MINOCA, and I really enjoyed the previous talk. It was very informative, and I think mine follows quite nicely. See? So yeah, as the previous speaker said, MINOCA is actually quite prevalent. Up to 15 of patients have this acute coronary syndrome and unobstructed coronary arteries. It is a diagnostic dilemma, as he very nicely said, and the mortality is up to 5% in 12 months, at 12 months. So it's not negligible, in other words, not such a benign condition as we thought it was. And all invasive and non-invasive imaging play quite an important diagnostic role. And cardiac MRI in particular, it's emerging as quite a key test to establish the final diagnosis. But I'm gonna quickly assess also the role of echo and the role of cardiac CT in stratification. So the role of CT, I think it got quite established, particularly during COVID, at least in Europe. And a lot of patients presented with non-ST elevation MI, for example, they have undergone CT as opposed to coronary angiography. And this is how we've been discovering also several MINOCAs. As you see during COVID, you can have also COVID inflammation and COVID myocarditis as a result. This study showed that in MINOCA patients, CT was able to identify, well, the absence of a coronary stenosis. But what they could identify was a pericoronary fat attenuation, so inflammation in MINOCA and Takotsubo syndrome, which is quite an interesting finding. And this is the only technique that can detect this pericoronary fat. as a marker of inflammation in non-coronary artery disease conditions. Echocardiography plays an important role because often we do this as a first line, even in somebody presenting with a STEMI, we do a quick portable echo on the way to the primary PCI. And often what we see is this balloon dilatation of the apex. The dilatation can happen also of the basal segments, but more typically is of the apical segments. And using contrast echo can be helpful in defining more accurately the contours, as you see here. The novel techniques like GLS, global longitudinal strain, can also help assess the extent of the regional wall motion more accurately. As you see, coronary angiography, LV-gram assess already the presence of apical akinesia and ballooning, as the previous speaker very nicely put, the octopus pot. We can also do a coronary flow reserve imaging with echo, and this is an LAD flux that you see, and this is in demonstration that the coronary is unobstructed. But I guess the application in practice is quite limited. You need to be quite an expert echocardiographer to be able to do this properly. Now, cardiac MRI has a very, very important role because it's a test that has many elements to it. You can do the regional wall motion anomaly of the left and right ventricle, but it's really the non-invasive tissue characterization that help us in making the final diagnosis. When we give contrast, we can see the presence of myocardial infarction or myocarditis. So the contrast accumulates, and is the myocardial damage that we can image. In this case, it's a large apical infarction because the distribution of the contrast is suggesting an infarction. We can also image myocardial edema. As you see here, this high signal intensity in the anterior wall and septum means edema. And these other areas here is remote myocardium, normal myocardium, which looks more gray. So it's really using those two techniques, late enhancement and edema imaging, that we can make final diagnosis in MINOCA. The way the contrast kinetics works is very simple, and I'll just explain you so the images in MRI will make even more sense. When you have a normal myocardium, you have preserved myocytes, a membrane, as you see here, and the contrast, which is an extracellular contrast agent, will accumulate in the interstitial space. And because in a normal myocardium, the interstitial space is quite minimal, then the accumulation of the contrast in the interstitial space is also minimal. And you don't have a lot of space for the contrast to accumulate. So the contrast washes in and washes out, so leaves the myocardium. And when you take a picture of this, you don't see any late enhancement, even though they're like small molecules here and there. When you have an acute infarction, the membrane ruptures, and this is the pathophysiology of ischemic heart disease. So now there is more space for the contrast to diffuse in this myocardium, and it can penetrate inside because the membrane is broken, ruptured. And so the extracellular space has increased, as you see here. So when you take a picture of this, you see the accumulation of the contrast agent. And this is why you have late enhancement. In the chronic scar, what happens is that the myocytes basically are necrosed, and then they become collagen fibers chronically. But the principle is the same. You still have increased extracellular space for the contrast molecules to accumulate. So also when you take a picture of this, you will see late enhancement. And the beauty is that the contrast does not accumulate in a random fashion, but it accumulates following the pathophysiology of the underlying disease. So we have two patterns, mainly ischemic and non-ischemic. And in the ischemic, you have a subendocardial transmural because of the ischemic necrotic wavefront phenomenon that starts in the subendocardium and then becomes transmural. And then you have any other pattern that's not subendocardial transmural, like a mid-wall late enhancement or epicardial late enhancement. And those are patterns that definitely not ischemic because an infarct will not start in the middle of the wall, and it will not start in the external layer of the wall either. And those two patterns are most typical for myocarditis, epicardial or mid-wall. And I'll show you some examples. In fact, what we can do with MRI is the following differential diagnosis. We can detect acute myocarditis because we're going to have inflammation in the outer layer of the heart. And then in the epicardium, we're also going to have scar with AP cardio, late enhancement edema, this is always myocarditis. With Takotsubo, we have intense edema transmurally in the area of akinesia and ballooning, transmural edema, but no late enhancement, as you see here. Then we have another pattern, which is small myocardial infarctions, like very focal, late enhancement here, and corresponding edema imaging. This is a small embolic infarction, can be secondary embolism, can be a plaque embolization. I won't be able to say at that point, but I think it does explain the ST changes and the symptoms of the patient, and it is an infarct. Here we need secondary prevention, here we don't. So it's quite important to find a diagnosis because it changes management. What do the guidelines say? Well, I was privileged to be part of the writing group of the 2017 ESC STEMI guidelines, and we included this table on MINOCA because there was an increasing recognition of this group of diseases, and there wasn't a very clear guidance of what to do. And we suggest either a non-invasive approach or an invasive approach. And in the non-invasive, CMR features in all differential diagnoses that we could make, and it complements echo very nicely. So when we suspect myocarditis, we'll do an echo in the first instance, but often is normal, no regional wall motion, and not pericardial effusion. And so CMR really complements the diagnosis very nicely. We can also detect small embolic infarction, whether secondary embolism or plaque embolization. We're still able to see small infarctions in the heart, and echo often can't because the small infarction don't come with a regional wall motion abnormality. We can also detect myocardial diseases like Takotsubo cardiomyopathy, for example, and whilst echo can identify regional wall motion and apical ballooning, sometimes these patients do have a large LAD infarct, in fact, even though they have unobstructed coronary arteries, because some patients do have spontaneous recanalization. And so not uncommonly, I've seen patients even in my own department, labeled with Takotsubo, but actually they had a big scar when we did the MRI. The fourth definition of myocardial infarction is another document that was involved and very privileged, and I introduced this new figure, which is the role of CMR in detecting myocardial damage, which the troponin detects. The MRI can help in distinguishing whether the etiology is ischemic or non-ischemic, and once again, is the usual patterns, transmural subendocardial, focal subendocardial. This is all ischemic patterns. Whereas the non-ischemic is more the myocarditis, mid-wall, and insertion points, and others. So really, this shows that CMR is really advancing into modern cardiology, including the guidelines, and so more and more centers are using it. The Americans also, they position CMR in a quite prominent role in this MINOCA position statement to say is the only non-invasive imaging modalities that has the ability to discriminate Takotsubo syndrome, myocarditis, or cardiac MRI confirmed infarct. So it should be a test that should be done. There is also an invasive approach, as also the ESC guidelines recommend, which is IVUS and OCT, and you heard from the previous speaker quite nicely his thoughts on that. The new non-STEMI guidelines of the ESC also mention quite clearly that CMR imaging should be done, and is non-ischemic and ischemic pattern that it's quite important to have to differentiate Takotsubo, other cardiomyopathies, or myocarditis. And in fact, the authors go as far as saying that it is recommended to perform CMR in MINOCA patients without an obvious underlying cause. So that means a coronary angiographic cause. Then you go on class 1B. So that you must do a CMR. So once before, it was more a recommendation. It would be important to do it. There was not enough evidence to really suggest a proper recommendation. For the first time here, we are actually now recommending CMR in class 1, so you must do it. I also brought you a couple of cases to translate these concepts into practice. A 52-year-old male with 2 hours chest pain and troponin 1,400 plus. This is the ECG, which shows basic ST elevation in the inferior and inferolateral leads. So obviously, First thing he does is a coronary angiography. On the way to the lab, there was a quick echo done, a portable echo with showing no regional wall motion abnormalities and no pericardial effusion. The angio showed unobstructed right and left system, so quite smooth. This is similar also to the first case that was presented today. Apologies. The MRI confirmed the echo findings, no regional wall motion abnormalities and no pericardial effusion. Then we continue with the MRI. There was presence of edema and late enhancement, and the distribution is epicardial mid-wall. So this is indeed a myocarditis, quite easy because the epicardial distribution. Then we have a similar patient, 48-year-old female, this time, no chest pain and no risk factors, troponin 500. The ECG is actually fairly normal, not really anything dramatic, and the echo is also normal, no regional wall motion and no pericardial effusion. Her angio was a bit different this time. The left system is totally unobstructed, and the right is small and diffuse, but there isn't a culprit as such. So it was a bit unclear what was going on with her, and we did an MRI to understand more. We confirmed that the LV was normal, no regional wall motion abnormality in any of the walls. But then when we did late enhancement, we discovered, to our surprise, that there was a small subendocardio, but looks almost transmural, but it's a fresh infert, so it can be overestimated. Nevertheless, there is subendocardio/transmural late enhancement in the inferior wall. I think it's probably more subendocardio, which is why there was no regional wall motion abnormality in transmural infarcts. There is regional wall motion. Anyway, this is the myocardial infarction. So you see that this diagnosis was also a bit of a surprise, and the patient was put on secondary prevention. Takotsubo cardiomyopathy, it shows quite nicely the edema in the anterior wall and not late enhancement. It can present also in a quite malignant fashion. You see here torsade as a presentation, and is probably due to the presence of edema and the alteration in electrophysiological properties and not to the scar. This is another case we published in my unit of a patient with ulcerative colitis who then had an episode of Minoka, and the angio was normal and the echo was also normal. The MRI showed focal areas of edema and coupled with areas of late enhancement, and this was confirmed also in the T1 and T2 mapping, which is the novel MRI tools. This represents an acute autoimmune myocarditis given the context of ulcerative colitis. So you see how diverse diagnosis can also be made. And similarly, this is a patient with amphetamine-induced cardiomyopathy. A patient had been sniffing 1 gram of amphetamine daily for 2 years at that point with chronic stunning and probably also toxic myocarditis caused by amphetamine. The patient developed a dilated heart, but also an ischemic cardiomyopathy here with a small subendocardial infert and a thrombus sitting on top due to the regional wall motion abnormalities. The study in Italy, Itami study, confirmed that because we have two patterns in myocarditis, you can have the scar in the infralateral wall or anterior. This study demonstrates that patients have this pattern and they have a worse prognosis than this pattern, which is more benign. In my department, because I have a big interest in Minoka, I would be doing this study that was also quoted by the previous speaker. I was very, very, very pleased and very honored. Here we capture the diagnosis before the cardiac MRI. So my clinical colleagues were asked to make a final diagnosis based on the clinical history, the echo, the ECG, the angios, the biomarkers, the usual diagnostic elements. And they made the diagnosis of myocarditis, which was confirmed in 34 patients, but actually 23 had actually an infarction rather than myocarditis, and 5 had Takotsubo. Patients thought to have MI actually had myocarditis, and some had Takotsubo. So in other words, all the boxes in black are diagnoses the CMR changed, and the one in white are those that we confirmed. So taking it together, we made a new diagnosis in 1/4 of the patient, so 25%. That new diagnosis led to a change in management up to 30%, so quite relevant. In 34, we made no change in the diagnosis, management as a result of the MRI, for example, finding a thrombus, but not changing the diagnosis. So altogether, new diagnosis management is almost 40% of patients that actually were positively impacted by having had an MRI. And so was quite clinically useful. This is another paper from my group on the prognostic role of MINOCA, and it's with the ECG changes, ST elevation, ST depression, cardiomyopathy, it can be ischemic, it can be myocarditis. What is the worst prognosis? And so here we demonstrated that cardiomyopathy has the worst prognosis and the infarct actually less so, because it tends to be a very focal, small infarction. Taking it together also with other elements, we saw that the combination of cardiomyopathy presenting with ST elevation, this is the combination that leads to a lot worse outcome. To conclude, there are novel techniques we can use in CMR, namely the T1 and T2 mapping, and the native T1 mapping is without contrast, which can be an interesting application. And so what we do now with this mapping technique is to rewrite the pathophysiology of cardiovascular diseases, and myocarditis here, for example, presents typical features of increased native T1, increased ECV, and increased T2 mapping. So that's quite interesting. There are criteria on how to report for myocarditis properly. And so in other words, there's a semi-quantitative analysis that we can do. And this is in the attempt to standardize this reporting. And just to conclude, the study that was presented at the American Heart just a few weeks ago is about OCT and CMR in MINOCA, and particularly female. And that was an interesting study. They ended up with 116 patients that had MRI and 140 and an OCT. 145 had only OCT, and the OCT could diagnose plaque rupture and various other coronary issues that could explain the thrombosis. But CMR ischemic and non-ischemic. And it's really the combination of the two that led to an increased diagnosis. So 46% only based on OCT, and 74% on CMR, and 84% if we combine the two information. So with that, I'd like to conclude that CMR really unlocks the diagnosis, can identify the acute myocarditis, Takotsubo cardiomyopathy, mitral infarction, whether it's embolic or spontaneous recanalization, and the finding. So it's the best single test to make the final diagnosis, and we can directly visualize myocardial damage. Thank you very much for your attention.
Thank you very much, Dr. Kayara, for this excellent and clear lecture. And I have for you only one question. First of all, we have also CMR, and it was the best way to diagnose our case. But I'm asking you, and if you have all the tools and all the equipment, which first diagnostic tool you use and for which patient?
Yeah, so in my center, because it's a large center, not all the PCI operators are familiar using OCT or OCT. Particularly, what we do is everybody gets an angio, and after the angio, everybody gets an MRI. Frankly, because 50 other angiographic testing, and then we review the angio if there is an infraction, and sometimes there is a small occluded vessel. Sometimes they bring patients back to the lab to do an OCT, but that's in selected cases. But everybody gets an MRI.
Okay. Thank you. First, Dr. Ayman Khairi here from Assut will ask you a question.
Thank you very much for your elegant presentation. I'd like to understand, what do you mean by acute myocarditis? What is the time limit for acute? Is it 3 months? Is it 2 weeks? Is it 10 days? What do you mean by acute myocarditis? Thank you very much.
Yeah, no, thank you. So I mean acute because of edema, and so acute in that sense. But what the papers I published that was cited is that if you do a CMR with your presentation, that's the highest diagnostic pickup, and so you're going to be able to make a lot of diagnosis there. I tend to recommend it to do maximum maybe within a month from the acute presentation. You can also do later, but then the inflammation will disappear because it's transient. And so you can still make the diagnosis, but maybe you're not gonna pick up all the diagnosis that you can if you do it more acutely. So I would say 2 weeks. If normally we do it as an inpatient in Bristol, or otherwise early outpatient, let's say within a month, I recommend.
We have another question from Dr. Amr Badri. He's our expert in cardiac magnetic resonance in our institute. Dr. Amr.
So thank you for the presentation. Is it possible to use CMR to detect microcirculatory disease in such cases with presenting with acute coronary syndromes? Thanks.
Yeah, no, thank you for the question. So the answer is yes, but I think more and more we can do this with the perfusion mapping, which is a sort of an advanced sequence that even in my lab I don't have at the moment. But often in those presented with MINOCA as opposed to INOCA, I think I don't find many microvascular reason. It tends to be either myocarditis or Takotsubo or small infarction. But the patient with INOCA, that yes, we do in MRI and we do find microvascular dysfunction. So yes.
Yeah.
Many thanks, Professor Chiara.
Yes, thank you, Chera, for this elegant lecture. I have 2 points. Number one, why do you put scads in the MINOCA? Already you have a lesion, so it's a dissection, so why not? The number two, the pericardial fat inflammation. How can you make it? And I know that's in a cardiac MRI, just by exclusion, because it's rare. I know that it's responsible for atherosclerosis, but how can this direct you in your thesis or studies in the management of patients of MINOCA?
Yeah, no, thank you so much for important questions. So it does not, you're right. In fact, that's why I emphasize my presentation on CMR, because I think among the images modality is the one that helps the diagnosis. CT, that was the only study on MINOCA that I could find to date. So it's more academic, as you quite rightly say. So it's nice to know there is inflammation, but it doesn't tell us anything. So that's why I would never do a CT in patients with MINOCA, frankly. I will do a CMR. And SCAD, so I've been doing quite a lot of patients with SCAD, and what we see is a small infarction as a result of the SCAD. So it kind of goes, it kind of refers us back to the coronary origin of the problem. So it would not be a myocarditis in that case. We do see a small infarction, or even big infarction, in fact, with the SCAD.
Many thanks, Professor Chiara. Actually, we have a question from Professor Khalid Baraka, Professor of Cardiology in Almenia University, about to what extent the stability or instability of the clinical condition may limit the use of MRI in ACS patients.
Yeah, so very good question, thank you. So the MINOCA, in my experience, they tend to be quite stable patients because they often the ejection fraction is even normal. And so I really scan them in just 1 or 2 days after admission. So that's fine. Sometimes we have the giant cell myocarditis patients, for example. So those are the ones that are more, unstable. So yes, patients need dynamically stable. So not coming down with a balloon pump or things like that in the MRI. But we can make the MRI quite short, up to 20 minutes. And so if that's important for the diagnosis, then we have done that. Even patients with a heart rate, 120 or something, because we're decompensated, we've been doing it. But yeah, we need to be careful.
Excuse me, a second question from the audience, role of CMR in diagnosing different types of myocarditis.
Different types of myocarditis.
Yes.
Yeah, so that's a tricky one because we cannot make the etiological diagnosis on CMR. I think that's where the biopsy comes into place. However, in my talk, I haven't spoken very much about biopsy. I find that in the ACS MINOCA presentation, the role of biopsy can be limited because it tends to be a myocarditis or the normal viral myocarditis, let's say, nothing kind of immunomediated for which you really need a biopsy. So yeah, I'm afraid we cannot make the etiological diagnosis. There was a study actually saying that if you have a mid-wall, latent onset in the septum, it tends to be more herpes virus 6. And if you have latent onset in the infralateral wall in the epicardial distribution, is more parvovirus 9. But I wouldn't recommend making virological diagnosis based on MRI.
Thank you very for Professor Chiara for this elegant talk. And for the time, we go to the next session. Thank you, Dr. Hussam, على our invite me to this program. Thank you, Professor Kiara. And go to the next speaker, Professor Dr. Hala Mahfouz, Professor of Cardiology من منوفية University. هتحدثنا إن شاء الله توك على المينوكا in a woman perspective. Go to Dr. Hala Mahfouz.
To thank Professor Dr. Hussam for his kind invitation to share this great gathering and excellent scientific program. And now we come to the women's perspective in Minoka. If we look at this red dress, in fact, it's not red dress, but it is red alert, because there is usually gender difference, and we have to take care of women when presenting with heart disease. So, particular disease mortality trends in men, as investigated by the American Heart Association since 1979, showed that there is a decline in the mortality in men, especially after the National Cholesterol Education Program started to introduce the strong and aggressive cholesterol management program. And that's why in male there is reduction in the mortality. While if we look at the female, there is still a quite higher and there is still a higher mortality than male when compared even at 2010. In fact, each year more women die from cardiovascular disease than from cancers combined. It comes even before the stroke mortality. For every woman that dies from breast cancer, there are 6 die from heart diseases. In fact, younger women are twice as likely as to die from heart attack than younger men. Let us go to this, an example of a presentation of woman, 55-year-old woman who doesn't see a doctor, mostly due to disinclination. She smokes, takes no medication, and doesn't know numbers about her cholesterol or her lipid profile. There is a positive family history of a prior heart attack. Now she develops a chest pain at home. She arrives in the emergency room with typical finding of acute myocardial infarction with positive troponin. An urgent evaluation is performed, then she undergoes a catheterization and no obstructive lesion detected, which means less than, it is not more than 50%. The patient is assured, and after treatment she went home. Again, like Dr. Chiara said, this diagram, we should follow the clinical presentation and to make sure that there is a non-obstructive coronary disease before to describe the presentation of the female. With Minoka, we have to exclude another 2 important causes like non-ischemic myocardial injury or overlook the coronary artery obstruction. In fact, women make up close to 50% of Minoka population, while it represents only 25% of myocardial infarction with obstructive coronary disease. Women presenting with acute myocardial infarction are more than twice as likely as men to have Minoka. And what we have to consider first in the patient presentation is the atypical presentation in women. They usually complain of something maybe not typical, retrosternal chest pain, which is radiating to both shoulder and back and the jaw. That is usually constricting, but in fact they may have just unexplained fatigue, shortness of breath, profuse sweating with unknown cause, sometimes having dyspnea, which may be neglected not only by her but even by her examining physician. When comparing this gender difference in the patient in the presentation with acute coronary syndrome, we found that dyspnea, nausea and vomiting, tension remaining significantly higher in women. Also fatigue, sweating, also still higher in female presented with acute myocardial infarction, but the chest pain usually not typical central, but usually arm pain, shoulder pain, which may be even neglected by her. Women, in fact, less encouraged to call emergency. And in one questionnaire from the women, only 53 of women would call emergency if they are experiencing symptoms of heart attack, while the same group of women said that 79% of them said that they will call emergency if another heart attack. But themselves may go something else if they have symptoms suggesting heart attack. They may go take medicine, to take aspirin, or she may call her physician to make an appointment for to go to the clinic, but not to the emergency department. Again, if she went to emergency room, in fact, she and less referred for appropriate treatment. Women with myocardial infarction are more likely to have complications and increased mortality, like I said in the first slide. Further, more and more trials try to address exactly women in acute coronary syndrome. Again, like my dear friend said in the two talks, the presentation of acute coronary syndrome in women, fewer women than men presented with STEMI, 27% versus 37% in men, while women less likely to have angiography, 53% versus 59% in men. However, severe coronary artery stenosis. Now, a gender difference. In fact, we are factors like smoking, diabetes, hypertension, the positive family history, but we're talking about the risk profile of the women. She's usually exposed to the menopause with profile and the associated increased risk of cardiovascular disease. Also, female patients usually have higher incidence and prevalence of collagen vascular diseases, autoimmune diseases, which is usually associated with high inflammatory and the chronic inflammatory process that may resulting in associated microvascular diseases. Also, a little bit maybe less activity programs, and again pressure or in the exposure of female during her fertile period and during pregnancy add more and more in the cardiovascular system, especially if the female exposed to gestational diabetes, preeclampsia, or polycystic ovary. All these are associated with the relative risk of subsequent cardiovascular disease. Again, depression and the cardiovascular disease, especially in female, while it may impact both gender, but in female, an independent predictor of coronary heart disease death. Vibration, in fact, may reduce the adherence of the patient to medication, which also will make an obstacle in if the patient develop coronary artery disease and then try to remove these issues still didn't improve the patient clinical outcome. So profile another study from Stockholm female coronary risk study that examined psychological stressor on the female. It was a little bit interesting because they investigated women who married or cohabitating with male partner worsened on the cardiovascular system in women more. Again, from the anatomical standpoint, the female patient had smaller size heart and still smaller coronary arteries, and this is sometimes not only increase the risk of stenosis, but also increase the risk of endothelial dysfunction, and they make it difficult a little bit sometimes during the coronary intervention. Now, how the gender difference in pathophysiology. Again, after my dear friends described the pathophysiology, but still there is some difference in the profile in the pathophysiology between male and female. While 40% of those plaque disruption, with 30% have rupture and 10% erosion, then the 25% the 24% may be the spasm with positive provocative test that relieve on nitroglycerin. Again, there is a gap or quite difference between the underlying pathophysiology between the plaque erosion and the plaque rupture with complete or incomplete obstruction of the coronary arteries. In fact, female usually suffer in men with aggressive thrombus formation that may be associated with the complete or incomplete obstruction of the lumen and resulting in the phenomena of Minuka. Once again, we need to stress that spontaneous coronary artery dissection that happens in Minuka, we have to put or to highlight it because during a pregnancy, female patient may be exposed to such spontaneous coronary artery dissection due to the hormonal effect, the stress, the impact of the pregnancy on the cardiovascular system that resulting in dissection of the coronary arteries with or without associated intimal tear. It representing about 25 to 35% of cases of women less than 60 years, which means during her fertile period. Again, I'm not repeated the Takotsubo syndrome. In fact, we have to discriminate these two issues because Takotsubo, this mechanical syndrome, in fact, affecting female patients and female gender constitute 90% of patients presented with Takotsubo cardiomyopathy. And that's why we have to differentiate the two entities because there is difference in the patient prognosis and patient management. Now, for the diagnostic accuracy, in fact, which is better, like Dr. Shara said, yes, the MRI is fantastic, important, but we need to know the figure of the predictive power of coronary artery disease in female. In fact, they differ. Female patients maybe not doing good for stress ECG. The sensitivity is low, about 60%, and specificity 70%. But the stress echo is the best of it because it has the higher sensitivity that reaches 86% and the specificity reach 90%. This is followed by the nuclear gate aspect with sensitivity 84% and specificity 90%. So if we need to investigate the female, so start with stress echo, full binuclear gated, and if we need to diagnose Minoka, so we go for MRI. In fact, these two nuclear imaging and echocardiography, still there is a progression and developments in the diagnosis of coronary artery disease, especially after the appearance of the deformation imaging and three-dimensional echo. Again, like Dr. Rishiara just said that in women, this category of 300 patients, 170 patients from these 300 patients were female. The 300 patients sent for angio, 170 of them have Minoka, and in fact, MRI was able to find the cause of myocardial infarction in 85% of women with Minoka in the HARP study. In fact, this is fantastic figure, and we hope that with further investigation, we found this important role in diagnosis of Minoka in women. And the CT angio, in fact, may play a role in the patient not, or there is a contraindication to have coronary angio, CT to provide the information about non-obstructive coronary disease in female may also seen. The gender difference in treatment efficacy. Is there gender difference? In fact, no. Similar benefit in men and women for statin, for antiplatelet therapy, for beta blockers, nitroglycerin, thrombolytics, ACE inhibitors. Both of them have the same impact, have the same efficacy between men and women. Regarding hormonal therapy, in fact, it is not recommended for the cardiovascular system or for acute coronary syndrome, but even it's not recommended by FDA. FDA approved hormonal therapy only for two reasons: for treatment of postmenopausal symptoms or for prevention of osteoporosis, and considering the lowest dose and for shortest duration. Again, for gender difference, we should, the red alert should make its impact on the general practitioner, because they have to no longer ignore non-obstructive coronary disease in women, can no longer assume a positive troponin or an abnormal stress perfusion test is falsely positive just because women's angiogram show no obstruction. And also we have to increase and improve the public awareness of the heart disease and how a typical presentation of the heart attack may exist. When female patients should have to seek medical advice and call emergency. And which is much better is to prevent the occurrence of Minoka in female. This is, we have to stick to the guidelines by preventing and treating the all risk factors, improve patient lifestyle, encourage her for healthy diet and the reduction of the weight. Smoking cessation is important. I went to the internet, tried to find what's going on from the clinical trials on the clinicaltrial.org and see what are going to do in the next years. In fact, I found two trials from the Heart Attack Research Program. One study that will investigate the platelet phenotype, the platelet genetic composition, and role of the platelets as effector cell in women and men. Both of them have Minoka. The study will takes place in United States and different participating centers. And they will take agent sex matched control. It is prospective observation study that plan to recruit 350 participants. They will make follow-up for them for 6 months at least, and the results will be released, expected to be released in 2025. Another study from the Heart Attack Research Program, or the HARP, about imaging. It's the multi-center diagnostic observation study that employing standard imaging protocol in patients with MINOCA to determine the underlying diagnosis in each participant, and it will make follow-up for the patient for at least 6 months and the maximum for 10 years, and would also release the results by 2025. So my conclusion, the prevalence of non-obstructive coronary artery disease in women among clinically ordered coronary angiogram is increasing and represent her commonest coronary heart disease. For women with MINOCA or who have other heart disease, keeping sex and gender role differences in mind when caring for can improve quality of life and outcomes for female patients. The next step needed to address knowledge gaps include evidence-based approaches to the definition, diagnostic evaluation, risk stratification, and the management of MINOCA patients, including large outcome clinical trials. And thank you.
Thank you very much, Professor Hala, for this very good lecture and very informative. I would like to ask you one question. Since the MINOCA is included in both ST elevation MI and non-ST elevation MI, do you agree that this MINOCA is a new name of the syndrome X, which we were accustomed to with, and was the presentation of chest pain and ischemia, and then we do the coronary angio and we find it normal? Or
Yes.
you don't remember syndrome X because you are
Yes.
young?
Yes, I have some research work on this area 10 or 15 years ago, in fact, because we didn't know exactly what's MINOCA, but we've been talking about normal coronary angio and the positive non-invasive imaging, and that was in fact very confusing and very challenging. What we're going to do with such a female? We will leave her alone and make her at home without any further follow-up or any further recommendation, or we will take care of her. But after these observational studies that included women in small numbers in these large studies, the prior large studies, they now put such a name, which is MINOCA or INOCA if there is ischemia. Try to address, this is a special category, needs special attention and a special further investigation to address what the prognosis will be in such a patient population.
Thank you, Dr. Hala, على very good elegant presentation. أنا كنت عاوز أسأل على المنوكا كإنسيدنس مع البريجنسي والمانجمنت، هل في difference بالنسبة للبريجنسي بالنسبة للwomen؟
Yes, this is one of the recently investigated issue, which is patient development myocardial infarction during the pregnancy. And we've been seeing that the spontaneous coronary artery dissection is the commonest underlying pathophysiology of such population because of the underlying hormonal profile and cardiovascular stress from the pregnancy and the physiologic effect of pregnancy on the cardiovascular system during the pregnancy, especially if the patient have prior cardiovascular dysfunction. So yes, the spontaneous coronary artery dissection, but we do not neglect the other precipitating clues like the coronary embolism, the endothelial dysfunction, the underlying myocardial diseases, or the presence of associated myocarditis if the patient develops. So the exact prevalence will be more and more determined or defined if we taking care of the patient with during this period and start to address which best test suitable for patient during pregnancy.
Dr. Hala, can I have a question to you? Thank you very much for this elegant lecture. As we are taking care today of Monica, and as Dr. Nabir said that it's common in females and young, and you have a different cause of menopause. Do you have touched any study comparing female and male regarding the mechanism? I mean, in female differs. I mean, maybe spasm or microvascular or SCAD or plaque ruptures or Takotsubo. How can the difference? I mean, is it these illustrations of all causes can be occur in male and female, or it is more common in female like spasm or SCAD? You touched this?
It's a good question. Yes, if we remember the WISE trial that was introduced a long time ago, since 20 years, it was the beginning of the women heart. And the research worked to address how the women heart differ. The first and the initial definition of the underlying pathophysiology is, yes, female patient may have coronary artery disease, heart attack, but usually, and the largest percentage is due to erosion and not due to plaque rupture. This is the initial one. But how to describe and to make the relation between MINOCA as a presentation and in women, and to compare this entity or syndrome with the female, is still, in fact, we need more and more trials and the large scale studies, maybe multi-center and multi-randomized trial to address exactly how they differ and why they are different.
Thank you, Professor Hala, for this excellent presentation and excellent discussion. And I would like to congratulate you to the new impact factor given to the Egyptian Heart Journal, being the chief editor of the journal. And we hope that you will continue the effort of Professor Mahmoud Hassanin to get the journal even better and better. Now, Dr. Khalid will present the next.
The next lecture will be by Professor Tariq Abdelhamid Kafafi, Assistant Professor of Cardiology, ASSUT University. The talk will be about role of interventional diagnostic procedures in MINOCA.
Okay. I don't know if you are going all to hear me without with the mask, or should I? I think the voice is okay. So I'm going to take the aspect of MINOCA into a different perspective, the perspective of interventional diagnostic procedures. Do I have a switch, please? Or from the laptop, from the keyboard? Okay. So looking into the mechanisms of myocardial ischemia, it's not only coronary stenosis implicated as a cause of myocardial ischemia. Actually, there are a lot of other causes implicated in the etiology of myocardial ischemia. So coronary microvascular dysfunction and vascular spasm are among the factors contributing to myocardial ischemia. Also, extraluminal compression by myocardial bridge is among the causes, along with a lot of other systemic inflammatory and platelet and coagulation disorders. So when we look to the two concepts of myocardial infarction with non-obstructive coronary arteries or ischemia with non-obstructive coronary arteries, we have two different tracks. The first is the track that is of ischemia with obstruction, and this is the standard cases that we usually see in our daily practice, either in a stable patient or in a context of an acute coronary syndrome. But there is another also entity, which is the entity of ischemia with non-obstruction, which is either due to vasospastic angina, which may occur transiently, named as Prince metal angina, or sometimes persistently resulting in myocardial infarction and even cardiac arrest. Also, another endotype is the coronary microvascular dysfunction. And this typically occurs in an obese male or female, most often in women, diabetic, hypertensive, smoker, and this results in a myocardial ischemia that is not associated with epicardial coronary obstruction. It is worth mentioning that these mechanisms can overlap. So there is some sort of overlap between atherosclerosis as well as vasomotor dysfunction in the coronary arteries. So what about the interventional procedures used in the diagnosis of MINOCA? Actually, there are either intracoronary imaging using either OCT or IVUS, guide wire-based measurements, namely FFR, fractional flow reserve, CFR, which is the coronary flow reserve, and the IMR, which is the index of microcirculatory resistance. This will be detailed later. Also, we have the vasoreactivity testing, either using acetylcholine most often or sometimes using ergometrine. Starting with the intracoronary imaging, we all know the oculostenotic reflex, where we usually the operators tend to overestimate intermediate lesions because of the visual estimation usually has a lot of inter and intra-observer variability. So the role of intracoronary imaging is very important in questionable lesions. It helps also to identify the underlying pathophysiology. Is the plaque disruption due to rupture or erosion? Is it a coronary dissection? Is there thrombus or not? And to identify what is the exact site of the culprit in non-obstructive lesions. We are often encountered with cases where we can see a thrombus in a distal traject of the artery while the culprit is proximal to this site of thrombus. So the intracoronary imaging has a very important role elucidating this. OCT and IVUS, when compared to each other, usually we know that OCT has higher tissue penetration. It has a better pathological characterization in terms of necrotic core, thin cap fibroatheroma, thrombus, stent apposition assessment, as well as dissection. Calcification remains a drawback for the use of OCT. So when we look to intravascular intracoronary imaging, if we have to choose, then OCT is preferred to IVUS because of the higher image resolution. Also, another application of intracoronary imaging is in coronary artery dissection can present either with obstruction or sometimes with non-obstructive pathology. With the three endotypes of spontaneous coronary artery dissection, intracoronary imaging stands strongly to elucidate the underlying pathophysiology. Is there an intimal tear, or is it just a false lumen with an intramural hematoma? And usually OCT has a higher resolution to detect this. Accordingly, in the latest NSTEMI guidelines 2020, the role of intracoronary imaging has been recently introduced as a Class 2A level of evidence C in the diagnosis of spontaneous coronary artery dissection. In this recently published study of the integration of OCT and cardiac magnetic resonance imaging in determining the underlying cause of MINOCA in women, among the women that have been screened, 170 have been found to have MINOCA. Of those, 145 underwent OCT and 116 also underwent CMR. OCT identified the culprit lesion in almost 50% of the patients, and CMR identified an ischemic etiology in more than 50% of the patients, and a non-ischemic etiology in almost 20%. However, it showed that almost 25% showed normal CMR study. The integration of OCT and CMR together led us to identify an underlying cause in almost 85% of the cases. So integrating them together gave and yielded better results. So we look to the integrated pathway of MINOCA management as we are dealing with a puzzle. So we put pieces together in order to solve the riddle. So coronary angiography provides some information. OCT tries to clarify this further, and MRI puts this information together and interpretable. Now, going to the next interventional procedures, which are the guide wire-based measurements and the vasoreactivity testing, and both are actually interrelated and usually are done in the same setting. We need to know why, how, and when to undergo this physiological coronary testing. But before going into why, how, and when to do vasoreactivity testing and to do guide wire-based measurements, we need to know the underlying pathophysiology of microvascular dysfunction. Well, there are a lot of underlying mechanisms entitled in microvascular dysfunction, from arteriolar remodeling to intraluminal obstruction by debris to extravascular compression by the edema in the interstitial tissue and by the elevated left ventricular end diastolic pressure encountered, as well as vasomotor abnormalities in the microvasculature and capillary rarefaction due to ischemia reperfusion injury. In cases of STEMI, intraluminal obstruction, sorry for this. In STEMI, intraluminal obstruction, extravascular compression, and vasomotor abnormalities stand as the underlying mechanisms. Microcirculation obstruction occurs by plaque debris and platelet neutrophil aggregates, and this can induce mechanical obstruction precluding efficient tissue perfusion. But also microvascular disruption occurs in the context of ischemia reperfusion injury with endothelial disruption that happens in cases of setting of STEMI. Microvascular spasm stands also as one of the underlying pathophysiological mechanisms of microvascular dysfunction. And this is usually an interchangeable mechanism of impaired vasodilatation and increased vasoconstriction. The impaired vasodilatation is either endothelium independent, induced by adenosine and catecholamines, or endothelium dependent, flow mediated by acetylcholine in the low doses, serotonin, histamine, and bradykinin, or it can be also due to increased vasoconstriction by endothelin-1 catecholamines, acetylcholine, and serotonin. It is worth mentioning that these mechanisms happen interchangeably and they can coexist. So back to why is measuring coronary microcirculation function important in cases or the context of INOCA and MINOCA? Well, to answer this, we know that the rationale for adjunctive testing of coronary vascular function, the so-called functional coronary angiography, is threefold. It's to present diagnosis, to implicate the treatment, and also it has prognostic influence. So first, we all know that a normal angiographic study does not exclude a disorder of coronary vascular function. And when we look to these two panels, this is the picture of a coronary angiogram. It only gives us information of epicardial coronary arteries because of the low spatial resolution of the coronary angiogram. However, we miss a lot of information that may be found in the microcirculation that represents 95% of the coronary circulation. Second, invasive physiological testing empowers the cardiologist decision-making in what we call stratified medicine. So when we identify the different endotypes of INOCA or MINOCA, we are able to distinguish patients and according to stratify the treatment in what we call linked therapy. So for the anti-anginal medications, we can see that in microvascular angina, we have certain drugs that can be given, and they are quite different from those in vasospastic angina. So when we reach a diagnosis and to differentiate the two entities, we can tailor the treatment more properly. So the third thing is that the coronary functional testing is not only diagnostic, its role also goes beyond this to prognostic information. And this empowers the clinician to adopt optimal guideline-directed preventive therapy and enhance the treatment satisfaction. When we look to this study about the microcirculation dysfunction and its role in future risk of heart failure with preserved ejection fraction, the so-called HFpEF, we can see that coronary flow reserve as one of the surrogate measurements used for the identification of coronary vascular dysfunction was associated with diastolic dysfunction. And there was an increased MACE and increased heart failure hospitalization among patients with impaired coronary flow reserve. Furthermore, integration of coronary flow reserve and the index of microcirculatory resistance shows that those with impaired coronary flow reserve and high microvascular resistance have the worst outcomes regarding the cumulative incidence of events. The patients who undergo provocation tests, those who yield a positive provocation test, usually have higher incidence of death from any cause, higher incidence of cardiac death, and readmissions for acute coronary syndrome compared to those having or yielding negative provocative tests, especially among patients with positive provocation who are declined the calcium channel blockers that should be properly prescribed in such patients. In this trial, the CORE-MICA trial, actually this trial was quite intriguing because it addressed a different aspect, which is the role of coronary function testing in stratifying the medical treatment. In this study, although it is a small study of enrolling only 151 patients, patients were randomized into two groups. Those undergoing an interventional function-guided care, and those undergoing only angiography-guided care. And the main primary outcome was the Seattle Angina Questionnaire with its details. So it's clear that the primary endpoint, which is the 6-month Seattle Angina Questionnaire, shows that summary score, the physical limitation, and the angina frequency were all better in the intervention-guided arm compared to the angiography-guided arm. Furthermore, the secondary endpoint regarding the diagnostic and clinical utility showed that patients offered the interventional-guided arm had more often changed diagnosis, had more diagnostic certainty, they had less, almost negligible misdiagnosis, and the treatment was changed based on this interventional approach was more often. And at 1 year, results, which was recently published this year, showed the consistent improvement of angina and quality of life among those patients. Now, coming to the next question, how should we assess coronary vascular dysfunction in the cath lab? The Coronary Vasomotion Disorder International Study, the so-called COVADIS, have provided a group of diagnostic criteria for identification of coronary microvascular dysfunction. It is very important to distinguish between epicardial conductance arteries and microvascular circulation. The epicardial arteries or the conductance arteries are usually the ones that we see in the angiography, but the coronary circulation are the ones that we miss in the angiography. We usually adopt two techniques. The first is adopting a steady state of hyperemia through adenosine infusion, as well as vasoreactivity testing using acetylcholine to induce epicardial and microvascular spasm. With the guide wire-based approach, it's not working. With the guide wire-based approach, we are able to assess the fractional flow reserve or the non-hyperemic pressure ratios using the FFR wire. And also with the pressure wire, we assess the microcirculatory resistance, either with the index of microcirculatory resistance or the hyperemic microcirculatory resistance. And there are certain cutoff values that have been generated that can assess whether there is microvascular structural abnormality or vasomotion abnormality or not. So an index of microcirculatory resistance that is more than 25 identifies patients having microcirculatory resistance. And finally, we come to the coronary flow reserve, which is also implicated in both epicardial and microcirculation. A coronary flow reserve that is less than 2 identifies patients that have impaired vasomotion. Regarding the epicardial spasm, when we induce vasoreactivity through provocation, we have to have at least 2 of the following: anginal symptoms, patients suffering from chest pain during the procedure, ST segment deviation, as well as impaired coronary flow assessed by the TIMI frame count or the TIMI flow. Added to this is the visualization of a more than 90% coronary reduction in coronary diameter in the epicardial spasm, the so-called Prinz-Mittel angina. There are different techniques. I'm not going to go into the details of this to assess the coronary flow reserve. It is also it is usually assessed automated using the dual sensor pressure temperature wire. with a special protocol that usually differs from one institute to another, that is giving us the final readings in this form. So the reading shows the FFR value, the CFR value, and the index of microcirculatory resistance. And according to these three readings, we stratify the patient into one of two groups. Does the patient have epicardial vasospasm or microcirculatory dysfunction? So the endotypes of Minoka are one of three possibilities. Either the patient has microvascular angina, vasospastic angina, or even he is a non-cardiac patient and we have to reconsider our diagnosis. Sometimes also there is a mix of all this. And accordingly, we stratify the patient in the treatment. So patients with vasospastic angina are given calcium channel blockers. They are giving long-acting nitrates or nicorandil. We should avoid beta blockers, and statins and ACE inhibitors are very important for event prevention, while those with microvascular angina shouldn't be offered nitrates. They should be given vasodilating beta blockers or calcium channel blockers, and remains also the ACE inhibitors and statins in the management. Finally, we come to when to measure coronary vascular dysfunction in the cath lab. Well, actually, looking to the interventional procedures, it still carries some sort of risk, although this risk may be very little or low. The risk of coronary injury with instrumentations, the transient bradycardia or the transient AF that can occur in the context of acetylcholine infusion. So the current indications of doing this coronary vascular tests are in patients with myocardial infarction with non-obstruction, the so-called Minoka, and those having developed a cardiac arrest that is not clear what is the cause or the underlying cause. So we tend also to do a provocation to reveal a possible vasospasm. Future possibilities to assess post-PCI patients. We are confronted with a lot of patients who after PCI of epicardial artery still complain of chest pain, and we need to further elucidate this, as well as patients with HFpEF and patients undergoing cardiac transplantation. The current recommendations gives a class 2A for guide wire-based CFR and class 2B for using the acetylcholine provocation tests. The key messages: interventional diagnostic procedures in the diagnostic workup of Minoka should be widely implemented in daily clinical practice. We are in the era of precision medicine, so the right treatment should be offered for the right patient at the right time. This should be our standard of care. And the practice of therapeutic nihilism and the gender bias should be abandoned. Further large-scale randomized trials are eagerly awaited to explore possible new therapies for such clinical dilemma. And thank you very much for your time.
Thank you very much, Tarek, for this excellent presentation. I have a question for you, please. When you have a patient with myocardial infarction and you do coronary angiography and you find the coronaries are normal, so the next step is to do left ventriculogram, or to do provocative test, or to do intravascular imaging. So how can you arrange these three steps for the management of this patient?
Well, actually, first of all, the LV angiogram should be done first, because it gives us a lot of information regarding the LV mechanics, and also it helps to elucidate some of the entities like, for example, Takotsubo cardiomyopathy. And also, doing the LV angiogram, we can measure the left ventricular end diastolic pressure, which gives us a lot of information. It should not exceed 10 millimeter mercury. So if it's exceeding this, we know that there is a problem with the microvasculature. So number one, while the patient's still on the table, we do an LV angiogram and we assess the left ventricular end diastolic pressure. And then comes, should I choose between intracoronary imaging or the functional testing? Well, this should be tailored according to what I am seeing and what my intuition is. So if we are confronted with some sort of coronary irregularities, some sort of abnormalities that are not quite clear, and I want to clarify it further by imaging, I would go for intracoronary imaging, OCT preferably. If I see some sort of vasomotion abnormalities, then in this case, I would go for functional testing with provocation, especially that provocation in the context of MI is a little bit risky, and some would be afraid to do it in the context of MI.
Dr. Mansour Mustafa?
Dr. Hassam, thank you for excellent meeting and very thanks for your inviting me. I think, Dr. Hassam, like the patient, already we see before the term of Minoka, and we see multi patients presenting with picture of myocardial infarction, and when we do coronary angio, the result is normal. I think there is some predictors as from the clinical of point, especially in young, in some population, there is a role of addiction in Minoka. I think it is very important because many the addiction between the young persons it is wide now, and also if we see the normal coronary angiography in young patient, we expected due to spasm, some drugs like cocaine and amphetamine, severe prolonged spasm can do this scenario. We can proceed for another test for diagnosis, or from the clinical predictors can give some medicine to prevent this scenario. And also, if Dr. Nabil available from the first lecture, if we diagnose the Minoka and the patient having coronary angio, mild suspected black rupture, around 30%, can we give freely anti-ischemic measures for this patient? And if we medicine, for how long time can give medicine? And also, as regard Dr. Tariq, if we see the moderate stenosis, unsuspected black rupture, everyone having a moderate black rupture with stenosis from 30 to 50% can send to do or can continue physiological assessment of this lesion or not? Thank you.
Thank you, Dr. Mansour. A lot of questions, and I hope to remember them all. First of all, regarding the role of drug-induced vasomotor problems in the coronaries, well, we see this quite often, and actually it has two implications. First, it unstabilizes a stable plaque, so if there is a vulnerable plaque, these medications can cause it to rupture or to erode. Furthermore, also, we can see the vasospasm, whether epicardial or microvascular, associated with these drugs. So yes, some drugs like amphetamines and etc. are implicated in the Minoka subtypes. Regarding the, if we find an irregularities or if we find some haziness in the angiogram, yes, if we are well equipped with intracoronary imaging, OCT or IVUS, I would go for examining the whole artery. It will not only help us to establish a diagnosis, but also it will guide me through the procedure. We are often encountered with cases where we find a thrombus in the distality of the infarct-related artery, while the culprit is quite proximal. So if we put the stent just jailing the thrombus, we did nothing actually, and we stented a normal segment, while the imaging modalities will help to unreveal the site, the proper site of the vulnerable plaque that has to be pacified by stenting. Regarding the management, as I have mentioned, according to the coronary function testing that was offered in Cormica trial and the protocol, which was very rigorous, as we can see, usually it helps us to stratify. So patients having microvascular dysfunction and patients with HFpEF, they do worse when they are prescribed nitrates. So we often prescribe just blindly to those patients nitrates, and the patient comes even worsened and complaining even more. And if we just do a provocative test and a function testing with the guide wire-based approach, we can unravel this and we can tailor the therapy properly for such a patient. So yes, I think that these new strategies and new interventional approaches will revolutionize our concept of Minoka and our way of managing these patients. I hope I have answered most of the questions.
Dr. Tariq, thank you very much for this nice lecture.
Thank you.
I think we have to differentiate between angina with normal coronary rather than myocardial infarction with normal coronary. The situation is different, because if you have an infarction with normal coronaries, first I agree with Tariq is LV angiogram. Do echo. Usually any patient going to the cath lab should do an echo. If he's suspecting an echo apical ballooning and then normal coronaries, do LV angiogram, just 20 cc, you find that taketsubo. The next step is to do OCT, IBUS. I think OCT is very difficult. It's not in all cath labs. It should be just be rented. So for such, IBUS is available, but it doesn't differentiate between plaque rupture and plaque erosion. So we have to stay for a couple of 3 days of the patient being stable, and then we go to decide. I agree with Tariq, imaging is important. The most important part nowadays is IMR. IMR is with Antonio Colombo in Italy and also in Greg Stone in the TCT group speaking about the IMR. That's coming to you, Tariq, regarding the IMR. Is it easy? I am from the generation of organovene a long time with, but now I'm not doing this. Sometimes it's very difficult to be encouraged to differentiate coronary spasm, non-coronary. Regarding the the index of myocardial resistance and the coronary flow reserve is the most crucial point nowadays of Menoka. My question to you, is it needs some precautions to do this, some wire facility, or you can do it easy for this? Can you explain to the audience how to do the IMR, please?
Yeah, thank you, Professor Sobhi, for these comments. Well, yes, I think the IMR, if we compare it to the coronary flow reserve, the IMR is more reliable because the coronary flow reserve, if you have an epicardial stenosis, it will not be reliable. Also, physiological alterations at rest, changes in heart rate and blood pressure will alter your outcome. So it could be a little bit tricky, but for IMR, it is more robust because it takes only the hyperemic indices. So if you look to the IMR, it is measured as what we call the mean transit time with the thermodilution multiplied by the distal pressure, the PD. So both these are quite stable measurements, and accordingly the yield, which is the index of microcirculatory resistance, is more reliable. And they have found that the index of microvascular resistance, microcirculatory resistance, is more connected to microvascular obstruction that is seen in the CMR. So yes, if I would go for a measurement for the microcirculation, IMR would be more reliable and gives us more information. There's another method which is called the hyperemic microcirculatory resistance. It's just the difference of the wire used. Either you are going to use the pressure, temperature sensor wire, which has a special platform, special console, or using the Doppler wire, the so-called combo wire, which gives a different result. So it's just like using the IFR versus the RFR. It's just different concepts, but at the end, they provide us with robust information upon which we can base our future treatment strategies.
So it's not like FFR, IFR? It's not.
No, absolutely not. No, I was just saying that IFR and RFR are two modalities that may simulate each other. So IMR and HMR also are two different modalities depending on which wire you are going to use. Is it the Doppler wire or the pressure temperature sensor wire?
Okay, thank you.
It's automated, but it's an equation. It's simply the product of the distal pressure measured by the wire and the mean transient hyperemic time, which is measured by the thermodilution, by injecting saline into the coronaries at a special 3 milliliter of saline wire in the distal vessel, and accordingly the machine automatically yields your IMR. A value that is more than 25, IMR more than 25, indicates that there is microcirculatory resistance, either due to vasospasm or due to obstruction. Less than 25 is an acceptable reading.
Thank you, Tariq. And for the time purpose, we will move to the last presentation in this session. Dr. Amr Youssef, Professor of Cardiology in Assut University, will present to us the final wrap-up and take-home message of the case and what we really did for this case.
Thank you, my chairman, my colleague. Return again to our case, which is introduced by Dr. Dina minutes ago. What is the next step? We find a case of myocardial infarction and coronary artery shows no significant lesion. What is the possible etiology of this case? What is the possible mechanism of this case? Let us go to what is the possible etiology of case of Minoka, classified according to the pathological mechanism to epicardial coronary artery affection, like unstable plaque, not detectable at angiography, epicardial spasm, coronary dissection, or microvascular affection, like microvascular spasm, and microvascular coronary embolism, or a case of Takotsubo syndrome or myocarditis, or a case of supply-demand mismatch. To solve this question, we must go to the second step of investigation, which is introduced by professor by a previous lecture, like IVAS, OCT, maybe functional test for coronary artery vasomotor test. Cardiac MRI is very important to diagnose myocarditis. We need transesophageal, contrast, ultrasound. All these tests may be needed to solve the problem. And all of the tests are considered second-level tests for diagnosis of a case of Minoka. In our institution, the best possible test for diagnosis of this case, is CMR, which is done in the same day. And now, Dr. Shayma Khidr, which is a lecturer of cardiology in our department and one of subspecialty in the CMR, will introduce the CMR of this case.
Thank you, Dr. Am. This case, as Dr. Am mentioned, he did an MRI the same day. And as we can see, we start with the SENI sequences, or the steady state pre-precision sequences. Okay. لا السني it's not. Okay. لا هو بس السني مش شغال. Yeah. As we can see, those should be the SENI pictures. So 4-chamber view, 2-chamber view, and 3-chamber view, and the short axis. So in this we can appreciate the wall motion abnormalities, the volumes, and we can calculate the volumes from the short axis images. And of course, they are all measured and indexed. Then we do the tissue characterization techniques like the T1 and the T2. Those are T2 weighted images. As Professor Chiara mentioned, they are for edema imaging, so we can see some increase in the signal intensity in the infralateral wall and in the lateral wall compared to the other segments of the myocardium. This is called edema imaging, so this indicates the presence of edema in this segment of the myocardium. And then we inject the gadolinium-based dye, and we take the images. There are early images and delayed images after the gadolinium, like a couple of minutes, and then 10 to 15 minutes thereafter. So in these images, the black should be normal, like the interventricular septum, but here we can detect in the lateral wall some patches of enhancement, whether in the early or in the delayed. These, the location of which are mid-myocardial and epicardial. This is confirmed here in the inferior wall also, in the 2-chamber view, and in the infralateral wall in the 3-chamber view. This is also seen in the short axis images, early and delayed. So given the Lately-Weiss criteria for diagnosis of myocarditis, there are the classical criteria. They 2 out of 3 of the following criteria, the T2 weighted images where we can find edema, the early enhancement and the delayed enhancement. So 2 out of these can diagnose myocarditis. The updated late use criteria, they excluded the early enhancement, and 2 out of 2, like the edema imaging in the T2 weighted images and the late gadolinium enhancement in the distribution mentioned by Professor Chiara, mid-myocardial and subepicardial can diagnose. Also, the updated criteria included the parametric imaging like T1 and T2 mapping. However, we don't have this yet in our center. So based on these criteria, we could make the final diagnosis of this case, and it was diagnosed as myocarditis. Thank you.
Okay, thank you, Dr. Shaima. It is a case, finally, of myocarditis. I terminate my lecture about this slide, which introduced by American Heart Association in 2019, and say that patient presenting with myocardial infarction may be by coronary angiography, obstructive coronary artery disease, and it is a case of myocardial coronary artery disease, and in this case we go to, as usual, coronary artery dilatation and stenting or other treatment of myocardial infarction, or non-obstructive coronary artery disease, and we have many causes like plaque disruption, coronary artery spasm, microvascular dysfunction, or coronary embolism and spontaneous dissection, and so on. And we can see now that the treatment is completely different by different causes. So I brought this slide to say the importance to know the mechanism of MINOCA, because the treatment is different by different mechanism. And actually I treat the case according to the etiology. Like in this case, myocarditis, I treat a case of myocarditis, not a case of myocardial infarction. Take home message. Myocardial infarction in the absence of obstructive coronary artery stenosis, it is case of MINOCA, is a syndrome with several causes characterized by a clinical evidence of myocardial infarction and the coronary angiography normal or almost normal, stenosis below or equal to 50%. More investigation like MRI, IVAS, OCT, TE, etc. may be needed to identify the etiology of MINOCA. Identifying etiology of MINOCA is important for further treatment. Thank you.
Thank you very much, Professor Amr, for this conclusion and the take-home message. And we are now know many things about the presentation of ischemic heart disease with normal coronary arteries, which we call MINOCA. And this MINOCA, it needs multiple investigation to reach to the conclusion. One of the most important is the MRI, as you see, and then the invasive techniques to rule out the rupture of the impulse or embolization, vasospastic, or severe narrowing of the coronary artery. But as a whole, MINOCA has a better prognosis than the obstructive coronary artery disease, and it is more prevalent in female than male. And we thank you all and end this session. Thank you very much.
السيشن دكتور عمرو، شكرا شكرا شكرا. ما لحقتش لا بس هي عايزه سلب الالجوريزم.